Well, good morning, everyone. An important moment.
The chairman, Nancy Wyden. You can sit right there.
Senator Wyden has always been a proud supporter of families, and I think we understand why. So good morning, everyone. I'm Jason Grumet. It is a distinct pleasure for me as president of the Bipartisan Policy Center to spend the next hour talking about something that is going right here in Washington, D.C. Authentic collaboration, as I think we all know, isn't easy. It requires principle, patience, creativity, empathy, and the tolerance for discomfort if you are truly trying to work with somebody who has similarly strongly held views and at times disagreement. But more than anything, it requires leadership. And so really it is terrific this morning to be honoring Chairman Orrin Hatch and Senator Ron Wyden, two leaders who have worked together to improve the lives of millions of Americans struggling with chronic health conditions. With support from Johnny Isakson and Senator Mark Warner, Senators Hatch and Wyden led the effort to adopt the Chronic Act of 2018. I am someone who respects a good acronym, so I should share with you that the full name of the legislation is Creating High-Quality Results and Outcomes Necessary to Improve Chronic Care. And if that's not a demonstration of good staff work, I don't know what is. So just a couple words about the actual accomplishment. When fully implemented, the law is going to provide broader health services for the chronically ill. It's going to support millions of vulnerable low-income Americans who are served by both Medicare and Medicaid. It's going to, I think, importantly expand the Independence at Home program, which will increase both the quality and dignity of care. And it will provide telehealth to millions of Americans. We were very proud to have the opportunity to work with the senators and their staff, and pleased that about a dozen of the recommendations of the Bipartisan Policy Center's health team found their way into the final package. But Senator Hatch, this morning also really gives us a wonderful opportunity to recognize your long and distinguished career in the U.S. Senate. The Chronic Act is but one of hundreds of bipartisan efforts that you have steered to success over 42 years. From working with one of our founders, Senator Dole, and President George H.W. Bush to bring the American with Disabilities Act forward, working across the aisle with Senator Kennedy, one of your dear friends, on the Children's Health Insurance Program, and frankly showing off a bit by working with Congressman Waxman to enact legislation that made it easier to bring generic drugs into the market. You have demonstrated something that we believe in very strongly, which is that you can be a partisan and a leader and a statesman, and we thank you. Mr. Chairman, I'm also struck by something you recently wrote when you stated that although nowhere mandated in the Constitution, civility is no less essential to the proper functioning of our government than any amendment, court ruling, or act of Congress. And so we want to thank you for your service to our country and your state. We want to thank you for what you've done to advance health care, and thank you for advocating civility in both words and deeds over 40 years. So, Senator, it's my honor, on behalf of our four founders and your colleagues, Senator Bob Dole, the late Senator Howard Baker, and Senators George Mitchell and Tom Daschle, and the BPC Board of Directors, to present you this award. I would also just note that we forged it out of crystal so that you'll be able to see the Presidential Medal of Freedom on your counter right behind it.
Well, thank you so much.
It's really terrific. You're a wonderful person. I think we're supposed to smile for BPC posterity. Thank you, Senator.
Well, that's very
Senator,
nice.
I think you want to just say a few words?
If I could, I'd just like to say a few words. I'm grateful to have my buddy Senator Wyden here. People thought that Hatch and Wyden could never get together on anything. But he was a lot better than I thought he was. He's a wonderful man, very, very energetic thinker, and one of my dear friends in the United States Senate. But thank you, Jason, for that kind introduction. I want to thank you, all of you at the Bipartisan Policy Center, for arranging this event. And additionally, I want to express my sincere thanks to all of you for being here today to recognize a landmark piece of legislation that I was proud to co-author the Chronic Care Act. Now, with your steadfast support, and we needed it, we were able to include the Chronic Care Act in the Bipartisan Budget Act signed into law earlier this year. This bill was the culmination of a bipartisan, committee-wide effort to streamline care, coordination services, and improve health care outcomes for Medicare beneficiaries living with chronic conditions. I think it's one of the most important bills we've passed this year. And frankly, I worked with my good friend, Senator Wyden, in so many ways. I have great admiration for him and love for him as a human being and as a friend. This is improved health care outcomes for Medicare beneficiaries living with chronic conditions like never before. And as more Americans with multiple chronic conditions come into this program, my colleagues and I wanted to ensure that Medicare would work for them. Now, I'd like to take a moment and just say a spectacular thank you to Ranking Member Wyden, who is here with me today. We've worked well together for a long time. People didn't think we would, but he finally saw the truth and worked with me. Actually, well, I saw the truth too. We both delighted in working together. He's a very, very human, good man. Besides, his wife owns the Strand bookstore, and that was good enough for me right there. I love to go up there and browse around, and they want to shower me with books, so I'm going to count on that in my retirement. We've worked well together for a long time, addressing important issues, but this bill was special. And I was honored to work together with Senator Wyden to make a real difference in the lives of people living with chronic conditions. This bill is evidence that Congress can identify a problem and address it in a bipartisan manner. The administration is now implementing policies of the bill, and I know that Administrator Verma is doing her best to ensure that beneficiaries get the improved outcomes that Congress intended. I commend her also for the agency's work to build off the reforms initiated by the bill by taking additional steps to focus on those with chronic conditions. I would also like to thank Senators Isaacson and Warner, who dedicated so much of their time, their own time, and effort to bring this legislation to fruition. They will never know, I don't think fully, how much I appreciate it. It is likely that this will be one of the last times that I will be addressing you as chairman of the Finance Committee, and I cannot think of a better legislative accomplishment to be addressing you about or to be celebrating near the end of my service than this one. I'm so grateful to be with all of you, especially with my old pal, Senator Wyden. People thought we'd never get along together. We get along really well, mainly because he's such a really good person, no question about it. And I like his wife's bookstore, too. I just want you all to know that we've appreciated the efforts that you have all put forward. We couldn't have done this without your help. So what you do is really important. It's worthwhile. It's crucial to us all up on Capitol Hill. And I think to the American people as a whole, and not just the American people, but people around the world who benefit from good health care in the United States of America and from the great ideas that we come up with as we work together. So thank you so much. I'll salute my friend, Senator Wyden, and get the heck off the stage so that you can get some real speakers up here. Thanks so much. It's great to see you. Where do I go? Do I go up this way? Okay. Thank you. Yes, sir.
Well, thank you, Chairman Hatch. It's an honor to be one of the last places that you are addressing the public in your long service as chairman. So I get a chance now to say a few more words about Senator Wyden. As I think many of you know, Senator Wyden has been a champion for health care long before he entered Congress in 1981. In the decade prior to his election, Senator Wyden helped senators and older Americans navigate the health care system as the co-director of the Oregon Gray Panthers. And we here at the BPC think that it's a real testament to his commitment, his unrelenting determination, and frankly, downright stubbornness that 4 decades later, you are continuing to champion the needs of senior citizens. We're very proud to have worked closely with the Senator on this legislation, and in particular, on the Independence at Home program, which we really believe is one of the more fundamental changes that's happened in our chronic care system in quite a while. As with Senator Hatch, the Chronic Care Act is just one of your many, many achievements and emblematic of a career of productive partisanship. To that point, in 2003, you joined Senator Lindsey Graham and Trent Lott, a senior fellow here at the BPC, to enact the Medicare Prescription Drug and Improvement and Modernization Act. Senator Wyden introduced the Healthy Americans Act with Republican Senator Lamar Alexander and the late Senator Bob Bennett. As I think you all know, the Affordable Care Act was quite bipartisan for a while until it wasn't. And Senators Wyden and Bennett had worked together closely and were instrumental in getting language that moved forwards in the final act that allows states greater flexibility in administering the law, which I think is one of the main aspects of success and hope going forward. Senator Wyden has also been bold, some might even say a little bit notorious, in taking risks to move healthcare policy forwards. With the constructive instigation of our dear friend Alice Rivlin in the audience, Senator Wyden joined with then House Budget Committee Chairman Paul Ryan to develop a cost constraint strategy for Medicare known as premium support, a good fight that is not over. Senator Wyden has always strived to make healthcare work better for families. I think the Chronic Act is just another accomplishment in a journey. We know that journey is not over. We are eager to continue to support you in that journey, and it is my honor, on behalf of the founders of the BPC and our board of directors, to award you this Bipartisanship Leadership in Healthcare Award. I think we're going up. I think we're. I'm told there's a spot.
Oh, great.
Excellent. A spot.
Oh, my goodness.
Thank you very much.
Photo opportunity.
Yeah, we're way on top of this.
Jason, thank you so much. And I'd like to begin, amidst all of the bouquet tossing that we're seeing this morning, I'm going to start by offering a few hard, documentable facts about health policy and this year. If you had said in the winter of 2017 that the Senate Finance Committee would write a bipartisan, improved 10-year reauthorization of the Children's Health Bill, CHIP, if you had said the Finance Committee would produce bold changes in child welfare that advocates like Marian Wright Edelman have dreamed about for decades, and if you would have said that the committee would launch a bipartisan transformation of Medicare to update the Medicare guarantee, if you had said all that would go on in 2017 and 2018, everybody, after they heard it, would be rolling their eyes and saying, "You are hallucinating. You got to be kidding me. It can't possibly happen in this kind of political environment." 10-year reauthorization of CHIP, transforming the child welfare system, updating the Medicare guarantee. Nobody would have thought that possible in 2017. Folks, it happened because of one person, and that is my friend, Chairman Hatch. And Chairman Hatch had a lot on his plate early in 2017. We could tick off all of the issues that has consumed him. And when we started talking about the topic at hand, the whole question of transforming Medicare, the chairman could have easily said, you know, I'm not sure we can do it. Let's think about that for a while, which in Senate language is about as blunt a no as you can get. And he knew that during my approximately 20-minute reign as chairman of the Senate Finance Committee, because as you know, Chairman Baucus retired, and then I took it for a short period of time. Senator Isaacson and I had developed this, and we knew that it wasn't possible to move something like this. So when Chairman Hatch had the gavel, I went, kind of hat in hand, pretty humble, and said, Mr. Chairman, because everybody expects your ability to build big coalitions, would you be willing to take this on, and maybe we can make it a committee-wide effort, which is exactly what the chairman decided to do. And he brought in Mark Warner, and of course Senator Isaacson stayed with it. And because the chairman was willing to take the time to do what he has done over the years, and Bill Hoagland mentioned that history with Senator Kennedy, and at one point I told him, I said, Mr. Chairman, I'm not Ted Kennedy, but I'm sure interested in trying to build coalitions with you. And the chairman said, that's what I want to do. So we're off to the races. And it all kind of started really with an awareness that both Democrats and Republicans had missed what Medicare has become. Medicare in 1965, I was director of the Gray Panthers in the 70s. I had a full head of hair and rugged good looks. Medicare was Part A and Part B. A for the hospitals, B for the doctors. And as the chairman and I talked, that's not Medicare today. Today, most of the money goes for cancer and diabetes and heart disease and strokes, chronic pulmonary disease. Medicare circa 2018 is hugely different than Medicare from 1965. And the chairman said, we can build on that. We can go now and try to build a bipartisan coalition. And without that decision by the chairman, we would have kind of kept treading water on Medicare. We would have been doing piecemeal things. We would have continued to kind of tinker with physician payments, kind of modernizing them. We would have tinkered with Medicare Advantage, the reimbursement rates, and the like. But we wouldn't have gotten on top of what Medicare has become had the chairman not been willing to say, I want to invest my time and I want to invest my capital in this. And now, Medicare, it's fair to say, is basically a chronic care program. I don't know any other way, to say it. Seniors with 4 or more chronic conditions accounted for 76% of traditional Medicare spending in recent years. So, a little bit about looking back. Now I want to start kind of moving forward just for a minute or two, and I promised the chairman that I'd keep this a filibuster-free zone. Today, every senior receives the same Medicare card, but they get their care in different ways. So the chairman and I said, with the support of our colleagues, let's come out of the gate and say that for all of the major ways in which seniors get their Medicare, we're going to start our chronic care bill headed in the right direction. So what we did is, there's traditional Medicare, that's basically fee-for-service. There's accountable care, that involves the providers. And then there's Medicare Advantage. And the chairman and I have always been interested in that. My state has the 3rd highest percentage of seniors in MA in the country. So we said, let's start by putting some points on the board for each type of Medicare. So for traditional Medicare, we were able in the chronic care bill to provide new benefits through telehealth for seniors suffering from strokes and people with kidney disease who wanted to get their dialysis treatment at home. and we were able to expand primary care services for seniors at home through what is called independence at home. Then move to MA, which is the more recent effort of private plans to sell coordinated coverage to seniors. There we were able to expand supplemental benefits that offer non-traditional services that have been shown to improve seniors' health. And BPC has been very interested in this, looking to expand things like nutrition assistance and safety measures at home. Then we were able, on the MA front, to cut red tape for the seniors who get Medicare and Medicaid, what's called the dual eligibles, so that we could better coordinate their care. And we gave those plans more flexibility so that a senior could get more tailor-made coverage to their kind of chronic illness. Then the chairman and I said, we've got to move to the accountable care organizations. And so what we said there was these more recent arrivals on the healthcare scene would be able to pick up the bills for seniors' primary care visits. And we also gave to the accountable care organizations more flexibility to offer telehealth. And I could give you more examples, the chairman could, with respect to each one of the three areas, but that's a little bit of a bird's eye view of how we tried to do it. We said, everybody's getting the same Medicare card, but they get their care in different ways, and let's start marching up the hill together, led by the chairman, to try to update the system. And as I say to all my Gray Panther friends, you know, what we're saying here is we're updating the Medicare guarantee. Medicare is a guarantee. Folks sit at kitchen tables from Portland, Oregon to Portland, Maine, and they can count on it. And now we're updating the guarantee. So I'd like to just close with a couple of suggestions about where we go from here. And it seems to me the first step we ought to do is make sure that a person is empowered for all seniors to be their advocate, to make sure that all of their care providers are pulling on the same end of the rope. So the point guard, Chairman Hatch and I are basketball fans, would coordinate with a seniors cardiologist, say, and a nephrologist to ensure that every provider had up-to-date records and treatment plans that would complement each other. MA plans, accountable care organizations, obviously making progress on this. We've got to make sure that seniors in traditional Medicare have that option as well. A second area that needs improvement is care for seniors after they leave the hospital. 4 in 10 Medicare seniors on Medicare who are living at home prior to a hospitalization and subsequent nursing home stay aren't able to live independently at home again. Medicare spends $60 billion a year on care for them after they leave the hospital. Unfortunately, a lot of those patients do not always get the quality of treatment they deserve. And I can tell you, I hear about it from hospitals. I know the chairman does. Often, you've got seniors who've been in a hospital, and when they're on their way out the door and discharged, people don't even know who to send the records to because there is so little coordination. Again, Medicare Advantage has a little bit better results right now because of the coordination effort. But we want seniors who prefer traditional Medicare to have the same chance as anybody else to go home after they've had a trip to the hospital. Seniors, from any vantage point, will prefer that. The last point is, I think there's an opportunity to update the Medicare guarantee in a bipartisan way to make sure that seniors, including those enrolled in MA, would have seamless access to palliative and hospice services. And the Congress ought to remove the barriers to seniors enrolled in Medicare Advantage and improve access to hospice. The Care Choices program that I offered in the Affordable Care Act really tried hard with the demonstration project to get that off the ground, but there were a lot of challenges with respect to MA and making sure that seniors had those options. I think, and the Inspector General has raised questions about this, we want to make sure that we address this question of hospice coverage and MA, and it's, I think, an area where, again, there's been leadership. Chairman Hatch mentioned Johnny Isakson. Johnny Isakson and Mark Warner have a long history of being interested in hospice and palliative care and end-of-life issues that bring people together, not generate the polarization and the animosity that we have had from time to time. I won't mention Sarah Palin. The last point is just this. If there's anything to take away from my remarks, it's that traditional Medicare cannot be left behind. Medicare Advantage offers flexibility for plans to try new ideas, but it can't come at the expense of the 60% of seniors who count on traditional Medicare or an accountable care organization for their care. I think it's important to bring that up as we get ready to close in light of the recent reports that the Health and Human Services Department is promoting Medicare Advantage plans over traditional Medicare. Medicare has got to be straight for seniors about all of their health care options. And I just want to emphasize that. That's not partisan. That's not political. It's Medicare, CMS, HHS. Be straight with the seniors about all of their health care options, with the federal government not favoring one type of Medicare over another. Even in my state, which, like the chairman's, has a high level of Medicare Advantage, we're the third highest, Medicare Advantage may not be the most attractive option in all corners of the state. So the Center for Medicare and Medicaid Services cannot become an advertising arm of private insurance or any other type of Medicare, because the role is to make sure that seniors get straight talk about all of their options. There's a lot to do in the days ahead, and I'll tell you that when the Finance Committee convenes in 2019, and Chairman Grassley and I, as you know, have worked together on lots of issues, pharmaceutical issues and the like, and he bangs the gavel, I'm going to think about my longtime friend, Chairman Orrin Hatch. This is some kind of public service career that we are honoring this morning. And Ted Kennedy used to tell me all the time, Ted Kennedy and Chris Dodd used to tell me all the time, well, you know, we're always talking to Orrin. You should keep that up. Well, it's one of the things we won't have in the United States Senate in 2019. And I just want to be able to say, and I know Nancy joins me in this, we're expecting to see the chairman and his wonderful wife, Elaine. Nancy's going to see you at the store, and there'll be plenty of books on hand. We want to wish them all the best for the years ahead. We know that they're going to be active on lots of issues and lots of projects. But I want to thank him for this friendship. I want to thank him for saying in the winter of 2017 that the chairman wanted to defy the odds. He wanted to defy the odds and make sure that the Finance Committee was on the side of folks that so often didn't have lobbyists and didn't have political action committees. The chairman made sure that they got a fair shake, and I want to thank him for it.
Good morning. I'm Bill Hoagland. I have the pleasure of working with our health team here, and I'm proud of the work that Catherine Hayes and Janet Marcher-Broda, and Dr. Anand Parash, and formerly with us, Ashley Ridlin. They all worked on the high-cost, high-need individuals, and their policy recommendations, as you heard, working with a number of people here in this audience, too, were considered directly in the development and finalization of that Chronic Act. I also want to thank the supporters of our work here on chronic care, particularly the SCAN Foundation, the Peterson Center on Health Care, the Robert Wood Johnson Foundation, and the Commonwealth Fund. Finally, before I introduce the CMS Administrator, as a former long-term Senate staffer, I just want to express my sincere appreciation to the Chairman and Senator Wyden for their kindness and their courtesies they gave me as a lowly staffer over those many years working in the Senate. I know I speak for Catherine Hayes also, who worked with the senators while she was on the Finance Committee. We are honored here to have the Administrator of the Center for Medicare Medicaid Services, Seema Verman, join us briefly. She's on a very tight schedule. She will not be able to take questions. But as an old budgeteer, I cannot help but note that the Administrator Furman oversees a $1 trillion budget. That's 1/4 of all federal spending in this one person. And I can't help but note that recently there was much ado about the fact that Amazon and Apple's market cap exceeded $1 trillion. I think it has fallen back maybe recently here on Tuesday and maybe this morning, but think about it. Administrator Furman budget exceeds $1 trillion today, and surely it's going to grow into the future. The Administrator joined the Trump administration in March of 2017 and has focused on digital health information, reducing paperwork, administrative burdens, advancing bundled payments, prescription drug costs, and earlier this week I was able and thankfully was able to attend one of her listening sessions on the issue dear to my heart, and that is rural health. I share her interest in rural health largely because I come from a rural part of Indiana and still consider that home, where the family farm is still located and operational on the banks of the Wabash. Administrator Furman also hails from Indiana, where she helped another friend of BPC, Governor Mitch Daniels, redesign Indiana's Medicaid program. So welcome, fellow Hoosier, and the Honorable Seema Verman.
Well, good morning, and I am truly honored to be with you here today. And I would first like to add my congratulations to Senator Hatch and Wyden on their awards. Their work over many years has advanced health care for countless numbers of Americans, and I appreciate their commitment to good policy. So as many of you know, I am new to D.C., and while I'm no stranger to politics, much of my experience has been on the state level. And there I worked to pass the first consumer-directed Medicaid program, and that was done on a bipartisan basis. And so that's the environment that I'm used to working in. And so based on what I had been told and read in the news, I expected a very different environment when I came to D.C. But actually what I have found is inspiring, because what I see that even in our disagreements, while heated as they are sometimes, many times, the energy of our arguments are not born from a political need to win, but from a sincere desire to do what is best for the American people. And while we might disagree on what policies would benefit our country, we find common ground on our commitment to improving the lives of Americans. And this is why I continue my work and remain energized. This sense of purpose gives me confidence that there is no problem that we cannot solve and no challenge that we can't overcome. And this event is especially important as our country mourns the loss of President George Herbert Walker Bush, a man whose life was dedicated to serving his country and to public service. And those of you in this room, especially our two honorees, can relate to the thanklessness that comes with public service. But I'm sure you can also relate to the sense of purpose that comes from giving all that you have in the service of others. Our time in public life is finite, but the legacies of dedicated public servants, such as President George Bush, will live on. And speaking of dedicated public servants, I would like to thank Senator Hatch. After more than 40 years in the Senate, he leaves a powerful legacy of significant bipartisan accomplishments for the healthcare system. He's worked across the aisle time and time again on so many issues, Medicare, Medicaid, the CHIP program, and he will be missed. And I would like to applaud both Senator Hatch and Senator Wyden for their leadership in advancing innovative efforts to modernize Medicare that will have a real impact on our beneficiaries. And we appreciate the work of Senator Isaacson and Senator Warner, who led the Senate Finance Committee's Chronic Care Working Group. Together, their work, born out of a commitment to the American people and improving the lives of Medicare beneficiaries, helped develop the provisions of the Chronic Care Act of 2017 that were passed as part of the BBA of 2018. Medicare was originally designed over 50 years ago to serve people with acute illnesses. But the needs of our population have changed over the years, and now 6 in 10 adults in the United States have a chronic illness, and 4 in 10 have 2 or more. Chronic diseases such as heart disease, cancer, and diabetes are the leading causes of death and disability in the United States, and they account for 90%. That's 90% of the nation's $3.3 trillion in annual healthcare costs. Now, I believe that good policy, really good policy, is bipartisan. Because when you get it right, both sides will love it, and the BBA is a great example of good, solid policy. This legislation modernizes Medicare to address the needs of the millions of Americans living with chronic disease. It will lead to improvements in innovation and quality of care for the millions of Americans dealing with chronic conditions every day. At CMS, we understand that relentless innovation is a crucial driver in creating value in healthcare, just like in other industries. And supporting innovation is part of our larger vision of moving to a system that is value-based, that rewards value over volume by bringing the best to patients. And when we start paying for value, we will foster innovation as providers look for ways to compete for patients by providing the highest quality care at the lowest cost. And there are many components of the BBA, but I want to call out of a few provisions that I think offer tremendous opportunity to advance innovation and improve the lives of our beneficiaries. And as you heard from Senator Wyden, the first area is telehealth, which has been a particular area of focus for me and is one of the most promising ways that current technology is changing the very face of healthcare. And we know that guided by what is best for patients, telehealth innovations could help usher in a new world of healthcare that is embraced by both patients and providers, that identifies new avenues of care delivery, and that improves the value of care by increasing its quality while lowering its cost. Telehealth gives patients choices. It gives patients another way to access care and puts them in the driver's seat as they seek out new options. It's particularly vital for our elderly and disabled populations, as well as caregivers, where transportation issues can be a barrier to receiving care. And using technology, a patient managing a chronic disease can connect more frequently with their team, with their healthcare team from home, and spend less time going to their doctor's office. Wound care, mental health counseling, questions and challenges related to medication adherence, lifestyle coaching. These are all areas in which telehealth is being used to improve care for patients and helping providers to deliver value to their patients. And telehealth is not just a rural health issue. Anyone who has faced DC traffic certainly understands that we could all benefit from the innovation in telehealth. And with the BBA, we can now offer access to telehealth services for all Medicare Advantage enrollees, whether they live in rural areas or not, and they can even receive these services directly from their homes. And I also want to call out the supplemental benefits flexibility. I think that this particular change is a game changer for the program. The BBA increases flexibility for Medicare Advantage plans to offer new supplemental benefits to chronically ill Medicare Advantage enrollees. And this flexibility is absolutely critical as we're looking at addressing the social determinants of health that we know have an impact on health outcomes. Every person wants to be independent, and they want to stay in their homes. Allowing plans of flexibility to provide new types of benefits, something simple as just a ramp or transportation services, a meal after surgery. These are very small things that can make a huge difference in improving health outcomes, keeping people healthy and out of the hospital, independent, and will ultimately lower healthcare costs. The BBA provisions will allow for better integration of care for people that are eligible for Medicare and Medicaid, our duals, by simplifying the administrative processes for these eligible enrollees to access the care that they need. And the dual eligibles are one of our most complex populations, and they're one of our most costliest as well. So these changes will make a real difference in improving the lives of those individuals. And we appreciate the extension of the vitally important Independence at Home demonstration, which improves care for Medicare beneficiaries with multiple chronic conditions. And it's allowing us to test innovation, figuring out ways to support people to remain in their homes as long as possible. And Congress has also provided us with new flexibilities for ACOs, particularly to allow patients to benefit from savings that are achieved by ACOs through new beneficiary incentive programs. And this essentially aligns the incentives for providers and patients to seek value, high-quality care at a lower cost. So it's not just the provider and it's not just the payer, but it's actually the patient engaged in seeking value. And collectively, the BBA changes will modernize the Medicare program, bring new benefits to our beneficiaries that will improve health outcomes and lower costs, and bring us closer to a value-based system. And I thank all of those that were involved in advancing this work and appreciate the efforts to advance good policy on behalf of the American people. But our work is not done, because at the end of the day, every American is concerned about the growing costs of health care. And by 2026, our CMS actuaries predict that we will be spending $1 in every $5 on health care. And that is not sustainable for our country. And I hope that we can all come together again, just as was done with the BBA, to advance good policy that will improve the lives of the American people while also addressing the rate of growth of health care in our country. So once again, I applaud and thank Senator Hatch and Senator Wyden for their leadership in advancing innovative efforts to modernize Medicare and supporting innovation that will have a real impact on our beneficiaries, and the Bipartisan Policy Center for your continued efforts to move beyond politics and focus on the policies that will advance the health and well-being of the American people. Thank you very much.
Thank you, Madam Administrator. We appreciate you taking the time to come over. We look forward to continuing to work with you and CMS in the new year ahead on these critical issues. Mary Agnes Carey, please, panelists, please join us. Mary Agnes needs no real introduction to the health nicks here in the crowd who follow her coverage of all things related to health in her current position as editor and senior correspondent with Kaiser News Network. She's had a very distinguished career in journalism from her very early days working in newspapers in Connecticut and Pennsylvania to editor of CQ Health Beat to Capitol Hill bureau chief for the Congressional Quarterly and as a reporter for the Dow Jones Newswires. We are very pleased that she would take the time to moderate our panel discussion. I'll let her introduce the panel as they discuss the implementation and going forward with the Chronic Care Act. Mary Agnes.
Great. Thank you so much. Thanks for that great introduction. I'm going to very quickly introduce our panelists so we can start our discussion about all the great, the key issues of implementation we've heard concerning the chronic care provisions of the Bipartisan Budget Act of 2018. So to my immediate left, your right, is Larry Atkins. He is Executive Director of the Long-Term Quality Alliance, and that's a community of organizations that's aimed at improving outcomes and quality of life for people with chronic health conditions. Next is Allison Schwartz. She's a former member of the House of Representatives from Pennsylvania, where she served from 2005 to 2015. Congresswoman Schwartz is the president and CEO of the Better Medicare Alliance, which includes Medicare Advantage plans, providers, and other stakeholders. Sean Kavanaugh is the Chief Administrative Officer of Aledade, which partners with independent practices, health centers, and clinics to build and lead accountable care organizations, which we also know as ACOs, that are focused on primary care. And Lena Walker is Vice President of Health Security at AARP's Public Policy Institute, where she leads a team of senior health policy and health services researchers. I'm going to start this morning with a few questions. I promise you the audience will get involved. So if you hear something interesting, make a note, and we'll have microphones to circulate when the time is there. So first, I would like to talk about this major component that allows MA plans, which we know cover about a third of Medicare beneficiaries, to target the non-medical but health-related benefits to individuals with complex care needs, rather. Plans don't have to offer these benefits to all enrollees, but they can target them to the people who might need them. For example, we just heard about the example the administrator used was a Medicare Advantage plan might cover the cost of a wheelchair ramp for individuals that have limited mobility, or perhaps low-salt meal delivery to people with hypertension. Larry, I know your group just did a report looking at plans. I want to start with you, but I invite all the panelists to jump in at any time on any question. What are MA plans offering in 2019, and what are they going to offer in 2020?
Well, let me start by just simply saying very quickly that, the Chronic Care Act is really a game changer, as I think the administrator pointed out. And what I think it does very significantly is shift the center of gravity in the Medicare program and in the healthcare system generally toward home and community-based care. So the Medicare supplemental benefit, the flexible supplemental, provides MA plans an opportunity, within the context of the Medicare program, to start to cover some of these non-medical benefits that are really often for people who have not only complex care needs and chronic conditions, but very, significant functional limitations. To be able to provide some of the supports that they need to be able to remain in the home and to be able to meet their needs. So our study interviewed 7 plans and in depth, and so it's a small sample of the plans that are out there. But of the 7 that we interviewed, only 3 were really submitting bids for 2019. A lot of that was because of the very short time frame and the fact that these are plans that had not been doing these kinds of services necessarily before, so that needed time to understand the cost. Sure. Right. So, but the major services that they are offering in 2019, I think, are a conservative effort to move into this space. There are things like, some limited food, because there is an opportunity to do post-medical, some of the post-medical foods, some limited transportation, only in cases where they are providing transportation to covered services, things like that, adult day services. So it's relatively conservative this year. There was a lot of enthusiasm in the plans across the board for moving into this space. And so I think that in 2020, a number of them are watching to kind of see how this plays out, and then also doing the work they need to do to be able to do good estimates on these benefits. And so you will see, I think, much more interesting kinds of benefits being offered in 2020. But I also think you'll see a lot more plans engaged.
Congressman Schwartz, I want to go to you next because you deal with these plans all the time. What are you hearing about their interest for 2020? What do you think we might see? And then, Lena, I know I saw your hand, so we'll go right to you.
Well, I think it is exciting, and I think, as Larry pointed out, we're going to see more activity on the supplemental benefits in 2020, probably because that's when the law kicks in. So what we've seen is an expansion under current rules, and that's useful to things like home modification. I think we have to back up a little bit just to say two things about this. One is, and I think that you heard this from Senator Wyden, and you certainly heard this from the administrator, that in an integrated system where there is care coordination and risk stratification, I think this audience is knowledgeable enough to know, where you can actually really start to identify, well, first of all, you have a population of patients you are responsible for, and then you're paid a capitated amount for, and then you actually can identify with sharing information between payers and providers, which is wonderful, new innovation actually that's involved in Medicare Advantage. You can identify these high-risk patients. So otherwise, the traditional healthcare system is you get sick or you don't feel right, you call for healthcare, right? Or you don't. Or you wait till you're really sick and you call 911 and go to the hospital. That's kind of our current system under traditional Medicare and mostly under traditional healthcare. It's really different when you're going to a group of physicians and other clinicians who actually have some responsibility for paying for your care over time. So what's been happening already in Medicare Advantage is the interest of like, all right, what are these patients' needs? We also have a lot of providers in our alliance really identifying what are the patients who need particular help, more help than others, and want to be able to address that. We've seen providers and plans already implementing supplemental benefits that are not available in traditional Medicare. And I will say, as a former member of Congress, we sort of made fun of these wellness fitness programs for a long time. They're just appealing to the young and healthy. Truth is, they really work for the sick and older. That they are
people who want to stay healthy
and want to stay healthy, and also recognize that we know this one more. If you're going to take care of your diabetes, if you're going to take care of your cardiac condition, COPD, you name it, hypertension, walking, socialization, eating right, all these things matter. They matter when you're 50. They matter actually maybe more so when you're 70. Sure. So just to back up to understand why this is such a good fit. So the opportunity for supplemental benefits, the expansion of the definition, because this isn't completely a free-for-all. CMS does a good job. Sometimes we want more flexibility, but they do a good job of assuring, are these, let's identify what's possible, let's look at what's happening, and let's create some rules around this, which is what they've done. The expansion of those rules to non-specifically health-related, but all related to chronic conditions, but the ability to provide services like transportation or even like meals. And I was interested in the administrator saying she still was tying it to post-hospitalization. What we're really hoping for is that CMS is willing to not wait until you have the surgery and do it post-hospitalization, but to allow meals potentially when somebody is frail and not eating right and has food insecurity and might end up in the hospital, to do that first. So that additional flexibility, we're going to push for this, and maybe some in the audience will as well, to see that CMS will do that. But we are excited for it. We've only seen a small uptick in 2019. Larry's done that. We have a report from Milliman that I believe is available on our website, if not today, this week, that actually talks about the 100 plans. There are actually more than that are growing what they're doing, but 100 plans who are experimenting with particularly care in the home, palliative care, and caregiver support. So there's tremendous interest in really what happens in the home and what we can do to make sure that what the plans and providers can do together to engage patients where they are.
Terrific. We look forward to that. Linda Walker, I know you had your hand up, and then Sean Kavanaugh, feel free to jump in.
Great, thank you so much. And I just want to echo what other two panelists have said so far, that this has been is a tremendous opportunity. So in the Public Policy Institute, we've looked at the data at some of the 2019 offerings, and what is really amazing is about 15% of the plans are offering caregiver support services, and I think you've mentioned that Milliman has seen that in the data as well. And this is something completely different from what has been traditionally offered in MA plans or even in traditional Medicare. So it is great, and we definitely are excited about where it's headed. I think others have pointed out that MA is a third of the Medicare population, so we still have 2/3 of the Medicare population, and how can we build in that flexibility for the rest of the
traditional Medicare.
Yes,
right?
that's right, in traditional Medicare. So I think that this is a great opportunity to think about how can we evaluate these new benefits. You know, how can we, this is a time for us to look at what new benefits are being offered, how does it affect overall Medicare spending, how does it affect caregiver well-being, how does it affect the patient's experience of care, and then with that experience and that evaluation, how can we think about offering that greater flexibility in the traditional program? I just want to point to the analogy with telehealth. So telehealth is being offered more broadly in MA, but then there's experimentation through the ACOs as well in that flexibility. So I think that's an area for us to look towards.
If I could just chime in, I share the support of everybody on the panel for this provision. My one caution would be, you're not going to see them offering everything seniors need. You're going to see them offering everything seniors need that has a return on investment for a plan, meaning the non-medical spend will be more than offset by a reduction in medical spend. And frankly, the plans and the world doesn't know a lot about that. And so I don't worry about what we'll see in the next year or two. I think we all need to give this time for the plans to learn what works within a confined budget, what has a return on investment. I think 5 years from now, the benefit offerings might be very different, and we will all have benefited from learning that.
I'd like to stay with you for a moment, if I might, because the issue of guidance, Congresswoman Schwartz brought that up from CMS, and I know, Sean, you had extensive experience with the Centers for Medicare and Medicaid Innovation. So placing that, you know, in the discussion, has the guidance from CMS been sufficient to plans, to providers? What's the appropriate balance between providing the right level of flexibility, right, to allow plans to determine what types of supplemental benefits to offer, and providing a sufficient level of guidance so that MA plans feel comfortable offering these services without fear of audits or sanctions?
Yeah, I think for the reasons we've all talked about, I think at the outset the guidance should be fairly broad. I think we should let 1,000 flowers bloom.
And has it been that way so far, or?
I think some of the early signals.
I would say that certainly it was a little narrower than we thought for 2019. We were hoping that they would include meals and transportation, even now a little more broadly. But it is, Sean can say it even better, it's getting it right. You know, it's getting the right oversight and actually enough guidance to also give plans and providers, who also take some of the risks, so they're involved in this, some guidance about what's allowed and what is expected, and also to create the right expectations for patients. I mean, you're right about that too. But this is a chance to innovate and see what works and to learn from that. So I think both of you have talked about that, the need to build the evidence to see what is most valuable, particularly for high-risk cost patients.
I would assume that,
really
assuming the plans do implement this responsibly, you'll see increasing flexibility from CMS over time, because it is unlikely this will lead to greater Medicare spending. I think the plans will keep their bids competitive.
And it's not extra money now.
Yeah.
It's really all within the money.
I think the real challenge will be, as we learn things in an MA context, just as you said, can you bleed them over into the ACO program or even into fee-for-service? And that really comes down to what level of, you know, risk are providers willing to take on? Because I think you see both the administration and Congress giving more and more flexibility to MA plans because it's a capitated program. The chance for it to drive up spending is very limited, which is not true in fee-for-service. So how do we take those learnings and integrate them in a different environment?
Larry, I know you want to jump in.
Yeah, Sean, I think you make a good point. And I think you have to keep in mind that these are supplemental benefits. So supplemental benefits are offered on an annual basis. Sometimes they're there, sometimes they're not. It really depends on how much room there is in the bid. And there's not necessarily going to be a lot of room in the bid because the plans are all going to offer the basic supplemental benefits first, which are much more attractive from a marketing standpoint, like vision and dental. And then to the extent that they have additional room in the bid, then they can offer these. So I think it is a test. I think we're going to be able to develop some evidence around the relationship between these non-medical benefits and medical savings, and whether or not it makes sense to be able to move from there starting to build these benefits into the essential benefits and give the plans the total flexibility to develop around individual care plans the kinds of services that people need to support them. And I think that's where we would like to go.
And I just wanted to go, but let's keep moving because we've got a lot to go through, people. I know this is exciting, but go for it.
So going back to sort of guidance for patients, I think one of the changes here is that these supplemental benefits can be targeted, and I think that that's really key because there needs to be, I think, more. This is a tremendous opportunity, as we said, but I think there needs to be guidance around what's marketed or how it's marketed to patients and consumers.
Exactly, that is one of the areas
because it's not clear if somebody will be eligible for the benefit or the extent of the benefit.
So how do you protect beneficiaries who think I qualify for this, and perhaps then they find out they don't? I mean, let's get into some of this idea about marketing concerns. Beneficiaries could see these advertisements. It could lead them to think, I'm going to get that new benefit. They sign up for the plan. The supplemental benefits may not be available to all plan members. How does CMS protect beneficiaries? How do people involved in this whole program protect beneficiaries?
Well, I think one of the big issues is the brokers have been out there pushing these benefits, and they're pushing them in a way that makes it sound like, hey, sign up and you can get all these great things you've never been able to get before.
These are the health insurance brokers helping with the Medicare
Yeah, just think you can get somebody, you can get a personal care attendant in your home. You know, this is great. And I do think there's a disconnect between the very targeted benefits and the limited benefits, because it's not like you get all the personal care assistance you ever would need. So I think it is a challenge, and the plans were very sensitive to this, by the way, the difficulty both in the plan finder of being able to communicate that level of detail, and also in their own materials, how to be able to communicate so that you don't get people signing up with the expectation. And I think one other thing is that there's a little concern about also in the communication that you start to attract, like you become the magnet for everybody who's got a really complex care need in the community, and whether or not we have enough, whether there's enough in the risk adjusters to be able to really take into account these very high levels of functional need that they could get.
And one thing I would say is that sometimes I think it seems harder when you're looking at things like home modifications or in-home care, but the fact is that the value of being able to target people who need it. I was going to say that in healthcare, we all sort of theoretically in Medicare have the right to get an MRI, but in reality, someone has to sort of suggest that that's a good idea for you, and then you have to learn the pros and cons of it and then decide to do it. It's not like everyone goes out and gets an MRI every day. I always used to joke, like, mammograms, colonoscopies, we're not all rushing to do those things. We're not overutilizing them. So I think some ways I think we have to be careful about the marketing to say this is targeted for people with chronic conditions. You can understand that if you don't have a chronic condition but would love to have a housekeeper, that's not what's intended, So but I think people understand partly because it's coming from Medicare that this is health related. This came out of the Chronic Care Act. There is a targeted audience for this, and but I do think that plans both kind of want to market this, but they also are very concerned that they don't want to oversell it either, because they don't want to have unhappy beneficiaries because they were signing up for a housekeeper. But I think we have some responsibility in both making sure that the guidance is clear about that and not overstating it, and at the same time being willing to say to somebody, this is targeted for someone much sicker than you are.
Sure. Walker, please.
I'd like to go back to Larry's point about the risk profile of who would be attracted by these benefits. So it's really interesting because this is not offering gym membership or kickboxing membership, so you're not going to be self-selecting the super healthy individuals. This really is for people who have multiple chronic conditions, and so it could change the risk profile. What I would say is, as you've noted, the benefits right now are quite limited, and I think it's sort of wait and see how the plans really start to develop these sets of supplemental benefits. And I'm not sure the scope of the services that's being offered. So I'm not sure to what extent the risk profile of the overall population in the plan would change. But certainly, I think that this is different from some of the previous concerns where you worry about, the self-selection,
not
right?
Eyeglasses. People who say you get eyeglasses, they know, all right, I only get them if I need them. But we know these benefits will not have a return on investment if they're not targeted. right?
Right.
So I wonder if they should be even at this early stage advertised at all. I think they should be part of a strategy health plans have to treat patients well and get the best outcomes. But I don't think it should be part about recruiting patients.
Larry, if you could quick
comment on that,
Okay.
Sean, because I think that's a good point. And the right now, plans can offer what are clinical programs under the in the MLR with the benefit part of the MLR. They can consider it part of the benefit. And in those cases, they are offering some of these kinds of things like care management and some of these other limited services. But it's done in the context of a clinical program so that there's actually an individual care plan in which it's identified that this would be important to be able to bring in individually. That's different than a benefit, which is a supplemental benefit. And so that issue about, targeting, yes, you can target it, but if you offer it, and if you offer it to a specific type of population, you have to kind of provide it to them.
So
and the question is, can you really get it into the care plans?
Great, okay. I want to move to something I think that's very important to everyone here, this idea of better coordination of benefits, trying to reduce confusion for people who might have a health plan for Medicare covered services, one or more plans for health-related Medicaid services, behavioral health services, long-term services and supports. The law requires integration of those plans. What does integration, what should it look like? Should an integrated health plan be a single entity? Could two or more plans sufficiently coordinate and offer these services, even if the plans aren't one and the same? What are the challenges to creating, if you can, a single pathway, a point of communication, single point of communication, especially for the duals? It's a big question. Who wants to start? All right, you're next to me. You get to go.
Okay. No, I think it's a huge question. I mean, so I think integration, one of the things with integration is communication coordination, which is really critical, and it's much easier to do if you actually have the panel of physicians, if you have the person's physician in your panel, right?
Okay.
And you have the relation, or in your network, and you have the relationship with them. And so if you're an TSS plan and you're providing long-term services and supports, you want to also have the health benefits for dual eligibles. We're talking about people who are in both programs. You want to be able to have the health benefits as well for both the ability to coordinate. So, trying to do it loosely across organizations is very difficult, or with fee-for-service is very difficult. And then I think the other thing is capturing the medical savings, because at the end of the day, that's where this has all got ahead. We've got to be able to show that these services, when they're provided, really result in a return on investment.
But let's
overall.
also think about the beneficiary experience in trying to find the right route.
Well, I'd say one of the things that we hear from beneficiaries at Better Medicare Alliance is that one of the reasons, one of the things they like about Medicare Advantage is a system. Some people talk about these networks, good or bad. The good of this is they can talk to each other, that there's a set of rules, that they, but they appreciate the care coordination, they appreciate the simplicity. They have MA and Part D. Most of them are MA PD plans. It's one bill, it's one payment. It's there's an annual limit on cost. Co-pays make more sense to them. But the most important thing, I think, from our point, we try to be agnostic about what's the best care model. Because actually, when we talk to our providers, each one has a different one. They describe it differently. But the essentials that make this work really require a primary care team that coordinates your care. And we should be willing to say that. It's really what it takes. And then a network of providers who can meet the needs of those patients and the ability to actually communicate with each other. It becomes a little more complicated, but they still do it with community partners. The capacity of all these community partners to meet all these goals instantly is a challenge. But in fact, that is the excitement of the challenge, is how do you actually integrate other services? How do you integrate these not traditional clinical services into that care model? And it's actually happening in a lot of situations. So I think, again, we're going to learn from this, but there's elements of a key primary care team that knows you and works with you and coordinates your care is essential to making this happen.
Thoughts on integration?
So this is from my experience at CMS, which is, I think everybody, it's universally acknowledged from the beneficiary perspective, this all should be unified, it should be seamless. From an administrator's perspective, it's an unbelievable mess. It's so hard. There are really well-intentioned people in states and at CMS who've been working on this for years, and it's really hard. Some of it's statutory, meaning they're fundamentally, Medicare, Medicaid, two different programs. two different sets of requirements. But even when you get the authority through the Innovation Center to waive a lot of that, there's two different cultures. I think it's worth working on, but and I was only on the periphery of this work at CMS. So, but when I looked in, I used to think, maybe we need to start from scratch. Like, there ought to be forget trying to reconcile these two things and just define a program that works for these folks.
Okay, Lena Walker, do you want to jump in first?
Yeah, so I think it's really, really important to adhere to sort of three principles. The one would be it has to be, whatever the process you develop has to be transparent to the beneficiary. They have to understand how it's being changed or how it's being laid out. And the second would be that it has to be easy for them to understand and navigate. So thinking about alignment in sort of time frames for Medicare and Medicaid, thinking about a single coverage determination process. So and then thinking about cultural competency and ensuring that any kind of process or documentation is available to people whose language is not, English is not a first language, or who have hearing impairments or other impairments. And then the third is, fundamentally the goal is to support individuals. These are individuals, the duals, who have multiple chronic conditions, right? So we need to think about ensuring that they have the highest level of protections.
So Larry, I know you want to jump in, but just to frame it up, continue on this, what happens to plans that fail to integrate? Might some plans cease to exist? Perhaps some of the special needs plans. But quickly, because I want to get to telehealth.
No, let me just quickly say that we have fully integrated plans that exist in a number of places today in the Financial Alignment Initiative, and in states like Massachusetts and Minnesota, and we have only 12% of all duals in the country are enrolled in integrated plans. So I think, Sean, you made the point. What else would you have for them? This is the only model that really makes any sense to put these two pieces together. But so the question is, so if you could really drive, and this legislation is intended to drive more integration and to drive to a more integrated level as what's acceptable under the definition of integration. And so you have these dual SNPs, special needs plans, MA special needs plans who serve the duals population. It is intended that they have a contract with the Medicaid program or that they're integrated in some way with the Medicaid program. And so at some point, the dual SNPs that don't have that go away. And so there is some attrition out of the SNP environment intended, I think, in this path.
Okay.
Well, the idea of the chronic care was to actually encourage more of them. So and to actually push states in some cases to have an integrated, coordinated office that really allows them to do it. I mean, we're seeing a lot of Medicaid managed care. A lot of that is really fee-for-service downstream. So the issue is, how do you actually move these things that have the same name that are really quite different? And so your point's quite well taken. How does a beneficiary figure that out when in fact they might have the same names, or they might all have different names and be the same thing? The need to simplify and to provide the right kind of information for beneficiaries is hugely important, and CMS has a huge role in this. I actually think the Social Security Administration has a huge role in this as well, because that's the first letter you get when you turn 65, and they would at least tell you have decisions to make. It's not just paying your Part B, you have other decisions to make, because right now, the majority of people, we've done some polling on this, the majority of people, beneficiaries in fee-for-service, traditional fee-for-service, don't even know there are other options. So they haven't even explored other options, and people certainly don't know whether they should sign up for a special needs plan or not. Right. So that becomes a referral. So we have a long way to go still to provide the information about what the options are for beneficiaries in ways that they can understand, in ways that are consumer-friendly to sign up.
What I would like to do is go to audience questions in just a minute, but before we do, I just want to give you all an opportunity to talk very quickly about the expansion of telehealth. And from your perspective, what that means for the folks you deal with, the plans you represent, what are some of the promises, what are the perils? I asked you a lot of questions, then I want you to go quickly. Lena Walker, maybe you could start.
Yeah, sure, happy to. So there's tremendous, we're happy about the expansion in telehealth. I think it improves access, and I think you cannot underestimate just how the added convenience really is an improvement. And it's not just that people want convenience for convenience sake, but people who are functionally having difficulty, mobility issues, caregivers who have dedicated themselves to taking care of their family members, the ability to access telehealth services in their homes, I think, is going to be a significant improvement in their quality of life and the quality of care that they will get. So one thing I would want to say is sort of a opportunity to think about improving it in the implementation stage is that it's imperative that the beneficiaries understand that they have a choice. And that they have a choice of having an in-person visit or a telehealth visit, and that there are no artificial barriers erected, for instance, to steer them one way or another, and also an understanding of who their providers are. So I think one opportunity, concrete opportunity, where we can really see some improvement is in the provider directory, for instance, being clear about who's offering telehealth services, and have it updated, so that you know that it's in real time.
Sean Kavanaugh, do you want to jump in on that?
Just two things real quick. One, I think we need to move from thinking of telehealth as a benefit to telehealth as a mechanism for delivering other benefits. And I think its origins reflect skepticism about it that we should have moved long past. In fact, we're so obsessed with telehealth, we're missing all these other technologies. And that's why I applaud CMS has tried to create fee schedule codes for email and so forth. When I get to 65, like the last thing Lord knows how I'll be communicating with my doc, but it won't be through a TV screen. So that's the big thing, is that we need to move past that, I think.
Okay.
Very quickly. Just say that this is also an example of where innovation in Medicare Advantage can really inform fee-for-service, because Medicare Advantage really picks this up, and I agree with you. It's one of the issues is what is telehealth, what is telemedicine, what's just another mechanism for talking to your doctor, our clinician, or getting your healthcare coverage. But I think that's really important because we're seeing, because I think it was picking this up more than fee-for-service was, they were taking a risk on it. You see it added to the fee-for-service benefit, which is just fine with just about all of us.
Great. All right. If you don't mind, I'd like to go to the audience, if you don't mind, because I know they've been waiting. Unless you had something really urgent burning. Okay. No, so we have mics, right? Folks have mics. I ask that you just tell us quickly who you are and go right to the question. No comments. We're a little short on time. I see somebody right here. Well, I think you want to, is there a microphone? We'll wait for the microphone, please, so we can all hear you.
Rick Blake, Strategic Health Resources. This meeting comes on the heels of another meeting last week where the Office of the National Coordinator for Health IT had their annual meeting. So when you guys talk about integration and all that kind of stuff, I think of real pipelines. And these pipelines are not nearly as connected or integrated to take on even this as we need. I mean, we have 5 major vendors and all kinds of disconnected systems. So my question to you is this Chronic Care Act a beginning or an end?
So how do we pull that all together, all the existing streams of information? Larry, why don't you start? Pipelines.
Yeah,
Thank you.
I think what you're putting your finger on is, what I characterize as the home is really the last frontier. That's, it's outside the healthcare system and it's disconnected. And so the electronic ELTSS initiative, the ONC has been pushing forward to try to create connectivity between the information that we're collecting in the LTSS space and the medical team. If you're really going to integrate, information is crucial to that. The information exchange, information sharing, and connectivity. We're a long way. I mean, we're really at the very start point. There's not even any data really, electronic data in a lot of places. So, but I do think that the Act helps to push more in that direction. Now, I think telehealth is a major part of that, but I think there are other aspects of that. And we have this law now from the Cures Act, 20th Century Cures Act, that requires electronic visit verification, and that will be another element of connectivity, and whether we can use that to be able to provide more information and flow back and forth will be a big issue.
Sean Kavanaugh, why don't you go ahead?
I think we've all been pushing for EHRs and the ecosystem generally to be supportive of value-based care, but the problem is all the users are making their living off of fee-for-service. And it isn't until
there's not the incentive.
It isn't until all the users are making their living off value-based care and they can say these tools are wholly inadequate for that purpose that the tools will adapt. And I think you'll know when that balance changes, when the tools and the ecosystem adjust to it.
Great. Okay, I think we had a hand over here. Yes, please.
Yeah, Michael Cook. I'm a healthcare lawyer at head of practice at a small national firm. Also sit on Virginia's Medicaid board. I made the mistake of writing an article once this immediately when
I need to go right to your question because we're kind of short on time.
The article talked about providing personal care ultimately as a benefit under MA. I'm getting tons of calls. Who do I talk to? And I know it's not a simple answer, but within a plan, is there a classification where you're likely to get somebody who's going to have the time to talk to these folks about A, can we do it, and B, what kind of data do we need so that we can circumscribe who can access this service?
Maybe Congresswoman Schwartz, could I kick that to you?
Well, I don't know the plans. I'm not sure I have a right answer to that, but I think that if you're interested in any of these innovations, whatever, but you're talking about home care, you're talking about that kind of personal care, I mean, you need to check out the plan, look at the specific plan, and what are they offering, and honestly, try and have a conversation. We talked about this isn't a benefit that you're going to have a certain number of days. It's not defined that way. Now, it might be. We don't know what CMS might do in terms of guidance. They may say on meals, you can only do it for 2 weeks. They may say you can only do it for 3 months. I mean, you can only do it for these categories of patients. We hope they'll be more flexible than that. And then the question is, it's really, at the end of the day, we hope these kind of benefits are, again, treated a little more like clinical benefits when you need them, when you are the right, right eligibility, you'll get them. But that'll differ by plans, too. There's no general answer here.
But might it mean that CMS needs to be very specific with plans to say you need to provide, I don't know, this amount of staff time, this amount of people on a call center, that kind of thing?
I think all of us on there might want to, I think we'd give the same answer. It's like we want enough guidance so there can be some rules of the road, but we want enough flexibility to really see what matters and works. To actually tie our hands now when we don't know what the answer is to that, I think is a real problem.
Okay.
Right. I agree on giving plans the flexibility to build out the program, but I think the issue is how do you convey that information to consumers and to beneficiaries, and there needs to be, I think CMS really needs to take the lead here and provide some guidance on how plans spell out what's available, note the limitations of the coverage. Now plans can offer, they can offer different, they're allowed to sell plans even if there are sort of small differences across plans. You can, so I think it's going to be, it could be really difficult and challenging with the proliferation of different options and different iterations of kind of the same benefit for beneficiaries. So we do really need more guidance from CMS.
Yeah, and just as advice to somebody, I would just say, if you're not in a plan and you're shopping plans, you should look on the plan finder, and you should also try to get the evidence of coverage from the plans, and it should be described in there. If you're in a plan, they probably should go to their primary physician, because many of these plans are using the primary physician as the kind of focal point for determining when somebody is eligible for one of these supplemental benefits or not. And also the supplemental benefits are marketed, so it should be available.
Terrific. Okay, we've got about 4 minutes left. You got a burning question, you got to move. Do I have a hand up? Somebody's pointing. Oh, yes, sorry, John. John Rother, beg your pardon. He's waving at me.
John Rother, and it strikes me that there's an unstated tension here between kind of different levels of flexibility. I'm a big supporter of the Chronic Care Act. I'm a big supporter of flexibility. But, Sean's definition of we're not going to talk about this and we're only going to do services that produce short-term returns is very different than thinking about this more broadly in terms of a health system and what makes sense. And that's very different than a third approach, which is what do people actually need in their lives to live and have well-being as they get older, which really is social services more than healthcare. So there's these three levels of interventions and policy that don't always fit together very well.
So how do we combine all of the elements you're talking about to work for beneficiaries accomplish all the same goals? Is that what you're saying?
Of course, but it does come down to money, right?
Okay.
I mean,
Yes.
it's how
Very
much money
important.
we have to commit to this.
Okay, Larry's got his hand up.
It does come down to money, but also I would say that when we talked to the plans, one of the things that came through that kind of surprised me was they said, you know, we really want to be able to attract and work with this population. I mean, obviously, look, this is a certain amount of low-hanging fruit here because if these people are being served very poorly and we can do a better job of serving them and providing them supports to keep them out of hospital and stuff, there's money to be had there. But it's also the opportunity. Look, this is what they want to do. They want to, their whole idea is to try to improve health. Take the population that's got the most complex health care needs and see if you can't make a difference. So I think there's an interest in moving into this area, not just for the money and not just because it's got to be ROI, but I think they go a little bit beyond ROI and thinking about things that make sense in this context for people.
Yeah.
But they're learning too, you know.
I think that's right. We've seen a lot of just keen interest, and I think some of this has grown from the plans and the providers to say, look, this is what people need. You know, we're giving them the clinical advice, but unless if they don't take the medication, if they can't go get it, you know, you name it. You know, if they don't have any of the supports they need, you're going to see them in the hospital in the end of the month. You know, so it's very real once you get providers taking risks and plans really taking this seriously, and we're seeing that. So I think this is a genuine interest. I agree, but I do think that John's also right that. Well, I guess I wouldn't worry about it too much, but I think you're right to sort of say that, look, let's see, I would say let's see where this goes. I think somebody said it, that, you know, it isn't going to solve every problem out there. It's not going to solve every housing problem. It's not going to solve every social support problem. It's not going to help you figure out, you know, live 500 miles away from my mother-in-law. How do I take care of her? I mean, these are real problems. It's not going to solve all those problems. But it has a chance to really address some key problems that could improve health outcomes for the complex population population with complex needs.
I want to reiterate my point. Like, either these things will have an ROI or plans will be raising their bids to pay for new stuff. I think the former is more likely than the latter. But then stepping back, you know, there is a continuum of social needs that people have. Putting an arm grab in the shower, pretty straightforward. Worrying about whether there's an apartment to put that arm grab in is very different. And I do, you know, this is a long-term discussion of how you better coordinate health and social. People have been talking a lot, fairly grandiosely, about healthcare addressing social needs. I used to work in a hospital. We didn't run the hospital very well. You don't want us running your apartments, you know. Like, there should be a division of labor, but then we got to figure out how we coordinate.
Great. Last word.
Yeah, well, I would like to say that I think that this opportunity of testing and evaluating and gathering the evidence shouldn't be just kept within the plan itself. So I think a lot of times private plans will evaluate new approaches, and so in this case, they're definitely going to evaluate what the ROI is on offering these supplemental benefits. But there needs to be a sharing of that information. And here's where I think CMS can play a role, where maybe they can provide the independent review or evaluation of what it means when you offer these benefits and what's the impact on overall spending or on the beneficiary or caregiver, because not all of them, I think not all of them will produce the types of savings or, you know, improvement in experience and care. They'll vary. And I want to end with this note that, again, this is a third of the Medicare population. So this is an opportunity to see what could work, what could be experimented beyond the MA population.
All right, and with that, I'm going to turn things over to Catherine Hayes.
Thank you all very much. Please join me in thanking our panel for their work today. And thank you for attending.
Thank you so much. Great job. Sorry.
Thank you.